Welcome to EQBloom. Today's topic challenges one of the most dominant models in mental health, the serotonin hypothesis of depression. For decades, depression has largely been seen as a chemical imbalance, specifically a deficiency in serotonin. But emerging science is telling a more intricate story, one that includes not only neurotransmitters but inflammation, immune signaling, and the deeper biology of mood. Let's begin with the traditional model. The serotonin hypothesis gained traction in the 1960s and became dominant by the 1980s. It posits that low levels of serotonin, a neurotransmitter involved in mood, appetite, and sleep, are responsible for depressive symptoms. This gave rise to selective serotonin reuptake inhibitors, or SSRIs. Like Prozac and Zoloft, these medications increase serotonin availability at the synapse by blocking its reuptake. And while SSRIs have helped many, we must recognize their limitations. They take weeks to work, if they work at all. In fact, up to 40% of patients experience no meaningful improvement, and remission rates are often low. So the question emerges, if serotonin imbalance is truly the root, why aren't we seeing more consistent outcomes? Enter inflammation, a powerful overlooked player in the story of depression. Emerging research over the last 20 years has uncovered elevated levels of pro-inflammatory cytokines, such as IL-1B, IL-6, and TNF-A, in individuals with depression, especially treatment-resistant forms. These immune molecules, when chronically elevated, can infiltrate the brain and disrupt emotional regulation circuits. Key regions like the amygdala, hippocampus, and prefrontal cortex show increased inflammation and altered activation patterns in neuroimaging studies. PET scans of patients with major depressive disorder have even revealed heat map signatures of neuroinflammation, particularly in emotional and executive regions. This suggests depression isn't just a mental or emotional state, it's a neurobiological event potentially driven by immune dysregulation. But how exactly does inflammation impact brain function? It starts with the blood-brain barrier, a selective gate that normally protects the brain. In chronic inflammatory states, this barrier becomes more permeable, allowing cytokines to cross into the central nervous system. Once inside, cytokines activate microglial cells, the brain's resident immune soldiers. While helpful in short bursts, chronic activation leads to excessive synaptic pruning, inhibition of neurogenesis, and increased glutamate toxicity, which can damage neurons. Inflammation also lowers serotonin and dopamine levels and reduces BDNF, a critical growth factor needed for neuroplasticity and repair. The result, a brain that's less flexible, less responsive to reward, and more prone to rumination, emotional pain, and cognitive fatigue. This isn't just sadness, it's structural and functional dysfunction at the molecular level. Now let's go even deeper into the biochemical landscape. Tryptophan is the amino acid precursor to serotonin, but under inflammatory conditions, tryptophan is diverted away from serotonin synthesis and shunted into the kynurenine pathway. This pathway produces metabolites like quinolic acid, a neurotoxin that overactivates NMDA receptors, increasing oxidative stress and even cell death in vulnerable brain regions. In other words, the more inflammation you have, the less serotonin you produce, and the more neurotoxic byproducts your brain must cope with. This may explain why some individuals with depression do not respond to SSRIs at all. Their biology isn't defined by serotonin shortage, but by immune activation hijacking the system. This is particularly evident in treatment-resistant depression, where patients show elevated levels of CRP, IL-6, and other inflammatory biomarkers. So if inflammation plays such a central role, how do we treat it? First, this doesn't mean SSRIs are useless. They remain helpful for many, but for a significant portion of people, we may need to expand our lens. Studies have shown that anti-inflammatory interventions like low-dose naltrexone, omega-3 fatty acids, NSAIDs, and exercise can reduce depressive symptoms, particularly in those with high inflammatory markers. Therapies like cognitive behavioral therapy, CBT, may work even better when paired with strategies to reduce inflammatory load, including sleep hygiene, anti-inflammatory diets, gut health, and stress regulation. We are entering an era of personalized psychiatry where tools like CRP and IL-6 testing may guide treatment plans. Instead of guessing which SSRI might work, we might soon tailor interventions based on a person's immune profile. This shifts depression from a chemical imbalance narrative to one of systemic imbalance, involving immune, neural, endocrine, and lifestyle factors. Let's take a moment to reflect. Depression is not a singular disease, it's a complex spectrum of syndromes with varied biological roots, and inflammation is emerging as a critical link between mood, immunity, and cognition. This doesn't mean every case of depression is inflammatory, but for many it may be the missing piece of the puzzle. It reframes depression from being just in your head to something rooted in the body-brain dialogue, something visible, measurable, and most importantly, treatable. So next time we talk about serotonin, let's remember the ecosystem it belongs to: the immune system, the gut, the endocrine axis, and your lived experience. Thank you for watching. If this resonated with you or gave you a new way to think about mental health, subscribe to EQBloom, where we bridge science and self and bring biology back into the story of being human.